Welcome back to another podcast from the Journal of Oncology Practice from ASCO. I'm Dr. Bob Miller, consultant editor at the JOP and medical oncologist at Johns Hopkins. In this podcast, we are going to be discussing a manuscript in the May issue of JOP entitled Physicians' Current Practices and Opportunities for DNA Banking of Dying Patients with Cancer, written by Drs. Quillin, Dr, Siminoff, and Smith from Virginia Commonwealth University in Richmond. Two of the authors were gracious enough to join me for this interview. Dr. John Quillin is a genetic counselor and researcher specializing in hereditary cancer at Virginia Commonwealth University's Massey Cancer Center. Welcome, John.
Thank you. Glad to be here.
And Dr. Tom Smith, who's speaking to us from a van somewhere in central Virginia, is a medical oncologist specializing in breast cancer and palliative care, and he is medical director of the Thomas Palliative Care Program, also at the Massey Cancer Center. And welcome to you, Tom.
Thanks, Bob, as I'm crossing the Rappahannock River into the northern neck of Virginia.
So your paper describes a missed opportunity, if you will, in the care of dying patients, something with the potential to benefit surviving family members and perhaps others. I'm sure the reaction of many oncologists, I know it was my reaction when I first read this, is I didn't know this was something I was supposed to be doing. So can you tell me a little bit about the background of your work and the importance of this issue?
Yes. I think as palliative care people, we have the family as a central tenet of the care, maybe even more than oncologists. So we're thinking about this, and oftentimes the whole family is there as people are dying. The second issue is this wouldn't be a problem if oncologists referred patients with the genetic predisposition up front at diagnosis or somewhere earlier in their course of disease to the geneticist. But the evidence at most centers shows that oncologists like me don't. I can say here at VCU's Massey Cancer Center, we regularly see patients who just never quite got to the geneticist for various reasons, but are now dying. And we have a 37-year-old man with colorectal cancer, or the 37-year-old woman with breast cancer and a strong family history who just for one reason or another never got to the genetics counselor. And about 20% of the palliative care patients we see have some genetic component to their disease, and very rarely do we see them being evaluated up front.
And I would say from the genetic counseling clinic standpoint, we often see patients who don't have a personal history of cancer themselves, but they're coming to see us because of family history of cancer. Because current genetic tests are very targeted, don't account for all families with hereditary risk, we typically recommend for these patients that they talk with their relatives who've had cancer about genetic testing first. But we get stuck, obviously, if those relatives have died and have not had genetics evaluation before they've died.
So what is the process for DNA banking? I don't know that everyone's familiar with that. Can you tell me a little bit about how it's done, how much does it cost, and typically who pays for it?
Very simply, it's getting a sample that contains germline or inherited DNA. That's usually a peripheral blood draw. There's some labs that can even do a cheek swab or something a bit less invasive, but usually a blood draw is best. So if in a pinch and a patient is dying, getting a couple of purple top tubes of blood and putting it in the refrigerator to keep opportunities open would be the starting point. There are several companies that offer storage of DNA. There's a very useful website called Gene Tests, www.genetests.org, and it lists, in addition to various laboratories offering clinical DNA testing and research DNA testing, also laboratories that offer DNA banking, as well as how to contact those companies with some very important information like how long storage is guaranteed. There's some labs that guarantee it for a set period of time, say 20 years. Some that guarantee it as long as they're available with opportunities to transfer it when they're not going to be available. You'll want to know how privacy is protected. Usually there's a contract and or a consent form that's involved so that those things are laid out, and patients or surrogates designate very clearly who has access to the sample, knowing about whether the sample would want to be, could be used for anything else, like research that's being conducted at the lab or clinical testing. And the cost varies, usually about $100. And this is not something, because it's not of immediate medical benefit, that would typically be covered by an insurer. So that would be something that the patient or family would typically be responsible for.
So is the $100, is that a one-time cost or is that an annual cost?
It varies by laboratory, and so that's certainly something to ask up front. A lot of laboratories do just have a one-time set fee. Others will have perhaps an annual maintenance fee.
So to focus a little bit on your paper in JOP, what was the specific research question your group was trying to answer, and what was asked of the participants in the email surveys that you sent out?
Well, we had suspected from our own practice that perhaps this was a challenge either here or because of patients we had seen, and recognizing that their family members who died had not had genetics evaluation. But we'd not seen it documented in the literature as to whether this was part of practice, whether physicians knew as you started this, if this was something they were supposed to be doing, or if this could be assumed to be happening upstream. So we wanted to know generally if this was on the radar for caregivers of dying patients. So the survey asked about current practices of hereditary cancer assessment and DNA banking, as well as knowledge, and then some measures of self-efficacy or confidence that providers felt they would be able to facilitate DNA banking. And then we also wanted to know, suspecting that this might be a challenge, what physicians felt could be helpful for them. So we listed several potential resources to facilitate genetics assessment and DNA banking, and asked what they thought might be needed.
And what were your major findings in the paper?
Well, in terms of general knowledge for hereditary cancer, it was typical for what other surveys had demonstrated of oncologists generally, that this group was similar to oncologists nationally in terms of knowledge. As far as we know, we're the only, this was the first to ask about DNA banking specifically, and in our sample, nobody had offered DNA banking within the last year of the survey, and very few, in fact, none felt confident to do so, and very few felt somewhat confident. So there certainly were the clearest deficits in terms of DNA practice and knowledge.
And just remind me, the audience for the survey, this was oncologists or palliative care physicians, or was it some combination of the two?
It was a combination. So eligibility for the survey was board certification in both palliative care and oncology. So
you showed that the participants who took the survey, as I think you said, they perceive their qualifications to actually recommend DNA banking to dying patients to be pretty low, and that there was also some room for improvement in their basic knowledge of genetics. In your paper, you talk about some web-based assessment tools, and I think you mentioned one of them. What are some practical examples where oncologists and palliative care physicians can go to learn a little more about this topic?
The website that I mentioned to help with learning about where one can find DNA banking facilities is the Gene Tests website. That also has a bit of educational information and background about what DNA banking is and what the individual's labs offer. There's a online brochure that's helpful both for providers and also we'll give this brochure to patients through the National Society of Genetic Counselors website. And that website is www.nsgc.org. We've also posted a brief primer online through the End of Life Palliative Education Resource Center website as well, and that gives just some general guidelines, not necessarily or not exclusively for cancer genetics, but any dying patient who might have a genetic component so that their family members might benefit. giving some guidance about triaging those individuals, how to talk to families, and how to facilitate the DNA banking itself.
Let me ask Tom Smith if I can. One of the recommendations in the paper was that the participants thought that the presence of a genetic counselor on staff might be helpful. But I was just trying to figure out how that might work in a palliative care program, since that's not an individual that you might typically associate it with a palliative care program. Tom, can you speak to that a little bit?
Yes. One other comment, too. ASCO has an excellent curriculum on genetics that's available from the ASCO homepage and even at ASCO University. So most palliative care programs don't have a geneticist, but it's something that we as oncologists need to make an established connection. So we should all have in our offices some established connections with a genetic counselor or genetic counselor team, so that when we see the person with unexplained breast cancer, prostate cancer, colon cancer, etc., we can refer those people easily. It's just like keeping a good relationship with an orthopedic surgeon or a neurosurgeon for emergencies. You want those connections already set beforehand.
In the paper, your group describes a series of actionable steps for genetics assessment and offer of DNA banking. It was figure 3 in the paper, and I thought that was very helpful. So maybe if one of you can just summarize some of the take home points that oncologists might find useful if they're faced with this issue.
Well, I would say, echoing what Dr. Smith had said at the beginning, not to assume that we can't assume that genetics evaluation has already happened for dying cancer patients, and that's often the reaction that we get when we present this idea to groups, is that shouldn't this be done sooner? Shouldn't this evaluation take place sooner in the disease course? And we agree that absolutely it should, but meanwhile it isn't. And so we can't assume that that's happened. And then secondly is to ask about the family history and to look for early onset cancers. So having bedside checklist is part of the intake process in palliative care for noting early onset cancer, asking about relatives and if there have been any individuals with the same types of cancer, if there's been any individual with multiple primary cancers or that early cancer, that you have a resource for contacting genetics, or again in a pinch, requesting consideration of getting a couple of tubes of blood for storage.
One of the questions that I was thinking about when I was reading your paper was about the role of the family and the caregiver in all of this. And I know you really didn't go into it in this investigation specifically, but what do we know about that? What do we know about caregiver attitudes toward DNA banking for their loved ones facing a terminal illness?
Well, from a research standpoint, there may be very little known about that, and so a lot of what we have is anecdote. There has been a little bit of interviewing in the UK, in particular, of hospice nurses asking about attitudes of talking with dying patients about genetics assessment, with some potential resistance. The idea that this might be an emotionally burdensome time and a stressful time, and not wanting to add whether that's survivor guilt to individuals in the family who aren't dying, or potentially a guilt to patients that they might have passed on a risk to surviving family members. Interesting, that's not been necessarily what we get when we talk with patients themselves about how they would feel about genetics evaluation. And so we've done a little bit of interviewing at our own institution of dying cancer patients who are generally positive about the idea of being able to leave a positive legacy, and others have found that as well, that folks do want to provide information to surviving relatives that might be able to benefit them.
That's what I was thinking, that the patient themselves might very well be very motivated to do something like this, but I'm guessing it's probably not something that is routinely discussed between patient and family. Probably almost never discussed unless a provider brings it up.
I think as medical oncologists, we have these long-standing continuous relationships with families and patients, which are really helpful. Sometimes when somebody's just first diagnosed with colon cancer or breast cancer, they can't think of anybody in their family who's had any similar disease, but as it gets known and the shock wears off and people have time to query their family members, you'll often get a very different answer when you're asking that question 18 months after the diagnosis. Oh, yes, I checked into it, and in fact, 2 first cousins have had breast cancer, one at 27 and one at 31. So we get more information than perhaps the surgeon or the radiation therapist seeing the patient the first time. The other part is that it really helps to have an established connection with the geneticist. I send a fair number of my young patients that I see to the genetics program, and uniformly it's a good experience. Whether they choose to have testing or not, they come away with more knowledge, usually motivated to do chemo prevention or better screening. I think it really helps their experience and will help future generations.
Dr. Quillin and Dr. Smith, thanks very much for joining me today.
My pleasure.
Thank you.
As a reminder, the full text of this article is in the May issue of JOP and is available to all ASCO members at jop.ascopubs.org. Also, as mentioned in the paper, an up-to-date listing of laboratories that offer clinical DNA banking services can be found at www.genetests.org. And as always, please send feedback about these podcasts to jopeditorsdesk@asco.org or comment in iTunes. I'm still waiting for my first iTunes comment. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.